Our next speaker is Dr. Dorothy Keefe on supportive care and the MASCC perspective.
Thank you very much. I feel a little apprehensive here because this meeting has been calling everything palliative care, and I'm here to talk about why MASCC thinks that actually the term supportive care has its uses as well. So my apologies to some of my dear friends who disagree with me strongly, but that's the great thing about friendship. You are allowed to disagree, you're allowed to have critical friends, and you are allowed to make sure that you're all thinking about the benefits to the patient. So MASCC is the Multinational Association of Supportive Care in Cancer. It has 800 or so members in more than 65 countries. And one of the great things about MASCC, apart from that I can't spell, is that it's multidisciplinary. It's formed around study groups with a specific interest in a particular area of supportive care. And I listed these three because these three are the groups that I'm actually a member of. So I'm a medical oncologist with an interest in mucositis. Every oncologist has to have an interest in antiemetics, and I have an interest in palliative care because actually we do a lot of what's been called primary palliative care at today's meeting. So there are actually 17 MASCC study groups, and the number grows, it sort of waxes and wanes depending on what's actually topical in the area. I've highlighted in red the ones that you maybe think would be the ones that would lend themselves more to what is commonly discussed as palliative care. Now actually you could probably call any of them either, but there's a sort of flavour that maybe these are the more palliative study groups. The newer ones include the skin toxicity from the targeted agents, and we may in fact need to do some specific targeted agent work as we go forward. So what is supportive care in cancer? It's the prevention and management of the adverse effects of cancer and its treatment, from early detection through diagnosis, treatment, survivorship or palliative care and end-of-life care. You can see where this is getting confusing. It includes both the physical and the psychological aspects of care. Our motto is that supportive care makes excellent cancer care possible, and it does. Supportive care in cancer alleviates symptoms and complications of cancer, reduces or prevents toxicities of treatment, supports communication with patients about their disease and prognosis, allows patients to tolerate and benefit from active therapy more easily, eases the emotional burden of patients and caregivers, and helps cancer survivors with psychological and social problems. Now, of course, it's not really my role to define palliative care because I'm not a palliative care physician, but there are many and growing and evolving definitions, but I like this one. Palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification, and then on it goes. Very, very similar, but focusing on life-threatening and early identification. So I put this in because we can have these discussions about what we call what we do, but really and truly, they're irrelevant as long as we're actually caring for the patients. There's room for both names, but maybe there's some emphasis difference. And I think the message I'm getting from the meeting is that we need to improve the supportive care at the beginning without detriment to the palliative care at the end. And I'm not sure we need to change names around to do that, but that's what we're saying. We're saying we're not doing enough support of the psychological needs at the beginning. I don't think the answer is changing the name of supportive care to palliative care, but it still gives us the message that we need to do better early in the disease. And the specialist difficult palliative care at the end must not be reduced. In fact, from the message I'm getting here, it needs to be enhanced even more. From MASCC's point of view, supportive care is the whole of the cancer journey, but only for cancer. Palliative care, of course, now certainly in countries like Australia, is about 15% non-cancer. So you can see there's another difference. And although we keep talking, the evidence is showing us very well that we need to integrate palliative care early into advanced disease. There's not a great deal of evidence that we need to integrate it in curable disease at the start. Now, these are the sort of great slides that everyone shows of the timing of what you do when, and you can argue about how you do it, but this would be MASCC's view that supportive care goes across the whole journey and that palliative care is an important part of that and increases across the journey. But of course you have to take into account the non-cancer palliative care, and this would be how you do it for something like respiratory failure. And the overlap is obvious, and this is a quote from Nathan Cherney, who basically everything's the same, that we aim to optimise the comfort, function and social supports of the patient and their family. One is in all stages and the other is when cure is not possible. Now, why is there confusion? I think that's quite an important question. The confusion is probably because the needs of the patients are changing. As we've cured more cancers and there are more long-term survivors, they have different needs. There's a bit of a problem with the image of the name of palliative care, and I think that I'll talk a little bit more about that later. And there's a bit of mission creep. I don't think we actually know where one starts and the other finishes. So there's a bit of a paradox here, in fact. At the incurable disease end, some palliative care services, Eduardo Barreras at MD Anderson, are actually calling themselves supportive care because it's less frightening. But at the other end, simultaneously, we're trying to call all supportive care palliative care. Now, surely those poor patients who got frightened at one end of their disease would probably get frightened at the beginning. So I think we have a question here about what's going on. So here are my scenarii that describe how I see the difference. So scenario one is an oncologist giving adjuvant chemotherapy to a 35-year-old woman with breast cancer with a 10-year survival of greater than 80%, and she develops nausea and febrile neutropenia from her first round of chemotherapy. So who should manage those side effects? There are options, obviously. My preferred option at this point would be medical oncology, because we are actually trained in symptom management. I've put the asterisk there because although I'm a toxicity expert, I do realise there's a lot to do in this area. But that doesn't mean we shouldn't do it. It probably just means we should make the medical oncology community better at managing the symptoms that we have, after all, caused. There's no need for an extra referral. The patient remains optimistic about her survival, and it is a bread and butter part of our job. And while there are times when we do need support and help, even early in cancer, if we outsource the bread and butter, we are going to become much worse at what we do. We need, as oncologists, to be doing what's called the primary palliative care. The option two is palliative care. It needs an extra referral, introduces the fear of palliative care. I mean, to have this 35-year-old woman turn around and say, "You mean I'm going to die?" is not a good look. Or, "You mean you can make me sick, but you can't help me when I get sick?" That's also a very bad relationship problem. And also, I'm concerned that with the amount of work palliative care specialty has to do at the end of life, if we start burdening you with everyone who's diagnosed with cancer, the whole thing will grind to a halt. In Australia, we do try this periodically, even at diagnosis of advanced disease, because the PAL care specialists say we want to see everyone at diagnosis of advanced disease. Right, here you go. Can they manage? No. And so we have to be able to make the right decision about who needs the referral earliest. So then this patient is cured and has ongoing survivorship issues. Who should see her now? Another options. So the survivorship service, area of great growth due to the increased cure rates and due to the fact that there are so many survivorship issues now, but the models of care, particularly in my country, are not fully developed. There's a lot of work that needs to be done. It's a growing area, and we need people in that area who are interested and qualified and skilled. That's probably not medical oncologists. And, with the greatest respect, I don't actually believe it's palliative care either, because, again, I think there's a huge amount of work for the palliative care people to do in the area of their expertise, which has traditionally been late in life. So, huge confusion. We've cured this woman, we've told her she's likely cured, and now we're going to send her to palliative care to look after the problems that we caused along the way. So again, I think it's tricky. Medical oncology is tricky as well, because basically the medical oncologists at this point are busy looking after the next cohort of patients that's coming in with problems that we can actually help. So I think it's something to do with sticking to the area where you're the best qualified. Obviously, I think this is a huge area for ongoing growth. especially as we have almost 14 million cancer survivors in the US, 6 million of whom are over 70, and 9 million of whom have survived for over 5 years. Now, if they all landed up in palliative care clinic, who is going to look after those with incurable disease? These are some of the issues. I won't go through them because everybody knows what they are. Obviously, palliative care and survivorship are very closely related and very important to each other, and I thought this was a great quote from Mary McCabe. There's obviously the great attention needed to both physical and psychosocial symptoms, interdisciplinary care, but in survivorship the key issue is the focus on identifying and managing symptoms in the post-treatment patient, and it's the successful completion of treatment and living well post-treatment. So there is a bit of a divergence between living well and dying well, and we probably need different people, or at least twice as many people if they're going to be the same ones, able to do this. So in most of the world, I mean, this is again, I think, an issue in the US differently from some other countries. In most of the world, palliative care teams are in such short supply and busy with advanced disease and death that this woman, the 35-year-old cured of her breast cancer, would not be a priority. In fact, if I referred her to a palliative care service in Australia, they'd probably refer me for a psychiatric assessment. So I think maybe primary palliative care is also part of supportive care and probably the province of the more acute oncology service. However, going to scenario 2, I don't think there's any disagreement here. We have a slightly older 56-year-old man with stage 4 lung cancer starting palliative chemotherapy, already has pain and shortness of breath, and the prognosis is guarded at best. Who should manage this patient? Well, I think it's going to be both. Yes, you do need an oncologist if you're going to be having treatment, but the medical oncologist is not going to be as good for the pain, dyspnea, quality of life, and as we've seen earlier in the excellent talk by Jennifer Temmel, this patient has palliative care needs and will do better with palliative care. So obviously we should be introducing shared care for this patient, and this will be one of the ones where palliative care increases as oncology decreases. And I don't think there's any argument. This business about the name, is very interesting. If you ask doctors who they'll refer people to, as the cancer gets more severe, more of them would refer to a service called palliative care, and fewer, but in fact everybody would always refer patients pretty much to a service called supportive care. So we do have this problem with the name issue. So I think it comes down to a couple of things. The name palliative is a bit scary for some, so a change to supportive have been suggested in some places. I do strongly accept the evidence that palliative care should start at diagnosis of incurable disease, but not at diagnosis of curable cancer routinely. That's where supportive care already sits and where supportive care has a big role. So my view is they're overlapping, but they're not the same, even though even the experts can't really delineate the boundaries completely clearly. So I think we're going to have to accept that there is a blurring of boundaries. They're both extremely important, and there's plenty of work for all of us. We don't need a turf war here. I don't think anyone in this room would be underemployed in their work with their patients, so there's no need for a turf war. But I do think that using only one of these names at the expense of the other would diminish the care for the patient. And since this is all about the patient, I think we need to keep them both. I think this is going to be my brave ending moment. You may never see me again. I think if we're serious about this meeting, maybe the name should be palliative and supportive. I'm going to stop there.